We're going to go ahead and get started. I'm Judy Newman and part of the Wellness Committee, and it's my pleasure to introduce tonight's speaker, Alyssa Aguirre. Finally got her name right. She is the Assistant Director of Dementia Care Transformation at Dell Medical School's Mulva Clinic. Dementia is a challenging condition and requires a multidisciplinary care approach from specialists across a variety of disciplines. Tonight, you'll learn about Mulva Clinic's multidisciplinary resources for those with dementia and their caregivers. Alyssa is a clinical social worker specializing in designing new models for dementia care and counseling individuals living with dementia and their caregivers. She supports patient-centered and evidence-based approaches to deliver innovative treatment and post-diagnosis support. She also coordinates several research studies focused on mild cognitive impairment and dementia. Her professional career has focused on Alzheimer's intervention, program development, research, and disease education. She's proud of her work on the Dementia Friendly America initiative, which provides education for healthcare systems and communities on ways to become dementia friendly. Her efforts support initiatives to educate future leaders who will transform healthcare and pioneer the advancement of dementia training and education. Please join me in welcoming Alyssa to Westminster. Oh, and if you would hold your questions till the end.
Thank you, Judy. And thank you, Debbie, as well, and for the community here at Westminster for welcoming me. This is my first time here on the campus, to my knowledge, and so I am so happy to be here with you all this evening. Thank you for having me. As Judy said, I'm a clinical social worker by training, and I'm also a researcher. And for me, my interest in working with older adults goes back to elementary school. When I was in 5th grade, our teacher gave us an assignment, and the assignment was to interview a resident living at the local long-term care community. And I grew up in Fargo, North Dakota. If you've never met anyone from North Dakota, now you can say you have. And so I grew up in Fargo, don't you know, and went down to the local nursing home where a lot of the residents there were from rural communities all across the state that didn't have long-term care communities. And so they were a long way from their families and their community and their loved ones. The woman that I had the pleasure of meeting with as 10-year-old Alyssa, her name was Violet. And she told me all about her life, and I spent a couple hours sitting with her, and I was so inspired by her life and her story, and I thought, when was the last time she got to share her story and her wisdom and her experiences? And I thought, this is what I want to do for a living. I want to work with older adults, I want to hear their stories, and I want to change healthcare. And that is kind of started me on this trajectory. And so I went to school for social work to focus on older adults, and I get to do counseling 1 day a week in the neurology clinic and do research. So I'll tell you a little bit more about that. So that's a little bit about my why, but what brought me to Texas was that I'm married a Texan, and if you know anything about Texans, is that they love Texas. And so it was maybe our 3rd date or so, and he said, you know, if we're gonna get serious, you need to know something. I'm gonna raise my family in Texas. And I said, let's do it. I agreed to that. And so we dated and got married, and eventually we moved to Texas because my mother-in-law was dealing with multiple sclerosis. And we did long-distance caregiving for a number of years, and it became really difficult, as any of you who've ever been long-distance caregivers. And so we moved here in 2014. We've been here 12 years now, and we moved here to help take care of her and kind of got to know the healthcare system here in Austin and what family caregivers were experiencing from our personal experiences and people living with chronic or neurodegenerative conditions, and really saw some things that were working well and some things that weren't working really well. And so my very first job out of graduate school was working at the Alzheimer's Association. So I answered the 24/7 helpline, and that helpline still exists today. If you call that helpline day or night, holiday, Christmas Day, anytime, a real dementia counselor will answer the phone. And what I learned from that job and answering that phone for 5 years was just the wide array of emotions that family caregivers experience. Sometimes people would leave the neurology clinic after just having gotten a diagnosis, and all they got from their physician was, call the Alzheimer's Association. And I got calls, people walked out to their car, picked up the phone and called the helpline. And what do I do next? I have this diagnosis. And so we got to kind of walk through that journey together. And so that's kind of my perspective as a clinician and as a researcher. I think it's so important to be in the community and learn from people because they know what's best. And so I'll tell you a little bit about how we designed the neurology clinic here in Austin that exists today. So many of you have probably lived in Austin long enough to remember in 2012, the citizens of Travis County voted to increase their property taxes and create a better healthcare system for Central Texas. And that is when the Dell Medical School began construction 2 years later after that vote. And so that building there right in the middle, UT Health Austin Outpatient Specialty Clinics, that is where our team sits in the Comprehensive Memory Center. It's a neurology specialty clinic. We primarily see individuals who are experiencing memory loss and have some form of dementia. The other buildings you see there are UT Dell Medical School Department of Neurology. That's the research building. I understand you've had some talks from Dr. Nemiroff and Dr. Bill Schwartz over the last couple of months, and that's where they do their research, and they mostly sit there. And then you can see in the corner Dell Seton Medical Center Hospital. And so the Comprehensive Memory Center has been open since 2017, so 9 years. We've been seeing patients in the clinic there. So while those buildings were being built, we got an amazing $50 million gift from the Mulva family to rethink how dementia care is provided. And not only for our clinic, but also multiple sclerosis and the bipolar center. So we had 3 clinics, and we really had an opportunity to do things differently and not just do what had been done before. And I'm so grateful to have gotten to sit at the table during those conversations. But when I think about what are the barriers to dementia care, it feels a lot like this picture. A long journey to a mountain and a long way up to the top of the mountain. So this is a picture that I took in Bolivia, and this really just encapsulates how I felt in that moment. Most people who, if they get a diagnosis of dementia, raise your hand if you've ever known someone living with dementia. Friend, parent, yeah, almost everybody. And so most people's experience is diagnose and adios. You get the diagnosis and that's about it. The door shuts and see you in 12 months. Maybe you get a prescription, maybe you don't. Maybe you get resources. Most likely not has been the experience of most of the people that I've talked to. There's a lot of barriers to specialty care. Primary care physicians that don't feel confident. 40% of primary care physicians who were surveyed last year don't feel confident in making an Alzheimer's diagnosis. There's also a lack of care coordination. You imagine most older adults see many different doctors, and one doctor, even in the same healthcare system, doesn't talk to the other doctor. And so when we thought about, okay, what are the barriers and how could we do things differently, this is what it felt like. But there's hope. In the midst of the mountains, there are rays of hope, and we really felt like we could do things differently. And so what happens when a social worker is sitting at the table to design a dementia clinic is you get to go out into the community and talk with people who are impacted. And so I'm sitting around this table with a bunch of executives and operations managers, and they have all these great ideas of how we're going to design the clinic. And I said, has anyone asked the citizens of Austin what they want? No. So we did focus groups in the community. I pitched this idea of running focus groups with partnering with nonprofit organizations where we would talk with people who are experiencing memory loss, learn from them what was their experience getting diagnosed here in Austin, what went well, what didn't go well. We talked with family caregivers. What could we improve about the experience? What's missing here in Austin? And how could we create a clinic that would serve you? And so we learned a lot of really great things from those focus groups. One was just getting a diagnosis and a stage, just starting right there. You know, what type of dementia do I have or does my loved one have? What stage is it in? What can we do about it? And then having that medical care provided under one roof. So you're not going to primary care in one place, and then the neurologist, and then the neuropsychologist, and then imaging, and you're running all over the city. Speech language therapy, your counselor, your psychiatrist, it's a million different places, and people really wanted care that was provided under one roof. The second thing we did was we interviewed other neurology clinics who we felt like were doing this well. And we asked them, where are your bottlenecks? What are your biggest problems? What could, if you were to start all over again, what would you do differently? What can we learn from you? And then we went to the literature and looked at best practices, dementia-capable healthcare systems, recommendations from AARP, from family caregiving, from the Alzheimer's Association. We put all that together. It took about a year to do the interviews, run the focus groups, and do our literature review. And what was kind of the main takeaways from that was what is now the Comprehensive Memory Center, where I am honored and privileged to work every day for the last 10 years. And so what we did with the Comprehensive Memory Center, these are kind of the main things that we tried to do to provide dementia care differently. We provide a more efficient path to diagnosis and treatment. Is it perfect? No. On average in the United States, it takes 18 months from the first time you have memory symptoms until you have a healthcare provider tell you that you have dementia. 50% of people who have a diagnosis of dementia in their medical record have never even been told that they have dementia. Lots of room of improvement there. And so one of our main goals was to have a more efficient path. How do we streamline this process to get people a diagnosis faster? We wanted an interprofessional team housed in one location, so all of those providers I listed earlier, we hired them based on their goal to work with a team, an interprofessional team. And so everyone was under one roof, so people weren't having to go to all these different places. We had a collaborative approach to decision making. So as a team, we came up with the name. As a team, we worked together on the website. As a team, we talked about what do we want our patient outcomes to be. We do research together. We even saw patients together. So the first couple of years I was in clinic, our advanced nurse practitioner, a social worker, a neuropsychologist, and a neurologist would all be in the same room as you doing the interview. We've since, pared that down a little bit to help us with our efficiency, but it was a wonderful way to learn with and from each other. I learned more about what a neurologist does and what a nurse does. I hope they have a better understanding of what a social worker does, because we all carry misconceptions and misbeliefs about what other providers in the healthcare system do, and really learn to value each other's expertise even more than when we had come in. The big one from my perspective as a family caregiver researcher is care for the caregivers. This unfortunately just does not happen in usual care. Caregivers are the invisible patient, and it's something I'm really passionate about. My grandfather had Parkinson's growing up. I watched my grandmother try to care for him and just struggle in the healthcare system to get people to listen to her, to get access to his medical records, to get referrals to any organizations that would help her. And so this has been a central key component to the Comprehensive Memory Center, and has really been a staple since the beginning. And so we offer counseling services for caregivers from the very first time the patient comes in the doors. They have access to a social worker, visits one-on-one, ongoing counseling services for the caregiver. We also do caregiver assessments. When we first opened our clinic doors and we were looking at the literature and trying to find what questions could we ask caregivers to understand their situation, we found almost all of them were focused on deficits and negative aspects of caregiving. Are they depressed? Are they anxious? Do they have high burden? No one had ever created an assessment that was strengths-based. What gives you meaning in your caregiving journey? What are your strengths as a caregiver? What are your needs? What are your goals for the next year, for the next 2 years? And because we couldn't find an assessment like that, we created one. And we spent the last 3 years validating that assessment. And I'm proud to say it's published as of this week, and it's being used across the country in a variety of settings. And so just one example of ways that we're really trying to not just impact caregivers here locally, but really make an impact across the country. From the focus groups, both caregivers and people living with dementia told us they wanted more involvement in research studies. They wanted to know what was the cutting edge research. What could they do to help reduce their risk of more progression? What could they do to slow down the disease? And so we've been integrating research studies since the beginning of our clinic opening. And then also collaborations with communities, which I'll talk about a little bit more on another slide. So this multidisciplinary team approach here is kind of these silos on the left. And what we were trying to do was something really different, which was an interprofessional team approach. So shared visits, shared documentation, our team briefs before we go into the room of the patient together, so we get multiple perspectives, and then we debrief afterwards. For every patient that's seen in the clinic, we have, it's 14 of us to 18 of us, depending on kind of our staffing, but we meet and we talk about the patient for 30 minutes to figure out, do we all agree on what we think the diagnosis is? What is the care plan? Not just what medications are we prescribing, but what support groups can we refer them to? Do they need a driving evaluation? Might they be interested in speech therapy? What research studies are they eligible for? And that really required all of us. Our psychiatrist, our speech language therapist, the social worker, the neurologist, all of us working together to create a care plan that wasn't just pharmaceutical, but was a whole person-centered, strengths-based care plan. And so we were really proud of that. And we know that patient care outcomes improve when teams are working together. People spend less time in the hospital. They have, let's see what else, I have my little notes here, lower medical costs, reduction in medical errors, and higher patient satisfaction, which is what we found in our clinic as well. So these are just a couple of pictures of the community collaborations. I was the chair of the board of directors at the Alzheimer's Association for the last 3 years. I've since stepped down from that role, but I have been pretty much a lifelong volunteer. Since 2007, when I was in college, I started volunteering with that organization, participating in their walks, and every year our neurology team has a walk team. On the top left, you can see it was a very, very cold November day. I think it was 30 degrees was the walk to end Alzheimer's that day. We were all bundled up, but the whole family got involved. It was really fun. And then the bottom left picture, I'm there with the students on the left, a master's student in social work, and then Roby, who's our research coordinator, there on the right at the caregiving conference at the Alzheimer's Association. So we partner with a lot of community organizations. So I'm sure you've all read in the news about this last week, the big announcement that the Michael and Susan Dell Foundation have pledged $1 billion with a B dollars to the UT Medical Center. And like many of you, I kind of wonder, well, what's up with that? How is that going to impact Dell Medical School? What is that going to look like? It's such an amazing, amazing, generous gift. And so I pulled this quick 2-minute video that has some clips from the press release, but also some mock-ups of what the Dell Medical campus is going to look like at the Domain. So hopefully this will work for us here.
$750 million investment will allow the UT Dell Medical Center to expand to include a 27-acre research campus right here in North Austin.
The future of healthcare is right here, right now.
Governor Greg Abbott said today's historic investment by Michael and Susan Dell means that next-generation medical breakthroughs will take place in Central Texas.
Now, with this new campus and new medical center, Texas will lead America in healthcare innovation as well.
This is what the new campus at Mopac and Breaker Lane will look like. Michael Dell says these images represent the intersection of medicine, science, and computing.
When you bring together a great research university, world-class talent, and a city that knows how to turn ideas into reality, you create the conditions for breakthroughs that change lives.
Dell says this will be a new kind of academic medical center. It will be the nation's first facility designed from the ground up for the artificial intelligence era.
What does that mean in practice? It means identifying risk earlier, often before symptoms appear. It means helping physicians make faster, better informed decisions in real time.
MD Anderson Cancer Care will be integrated into the new medical center. Last year, thousands of Austin area patients traveled to Houston for leading edge cancer care. In many cases, that will no longer need to happen.
However, this relationship is different. Through UT Dell Medical Center, we deepen our commitment to this community by providing our world-class cancer care right here in Austin.
Construction of the new research campus is already underway and should be complete in 2030. Betty Cross, CBN.
All right, so that is pretty exciting news, and now you all know exactly how much I know about this new investment, which I can't wait to learn more about. Dean Lucanetti is having an all-hands meeting next, end of next month. Oops. Okay, let's see if I can, this is the trick, let's see if I can get technology to work here. So I'm hopeful that, I think we had to learn a way to close that one. Okay. So we're having an all-hands meeting at the end of May, and so I'm anticipating getting to learn a little bit more about that. But I think the key takeaways is that these new hospital systems will be AI native. What that means exactly, I'm not sure, but we know that precision medicine is going to help with early detection, and it's going to be embedded from the beginning. It's also a collaboration with MD Anderson, the Cancer Center, and we'll have the new research center as well. So very excited to see what's going to come from that. And so while we're on the topic of generous donors and money, I want to tell you a story. About 4 years ago, I got a phone call out of the blue. I had met a program officer with the Department of Health and Human Services, just kind of in passing at an event I went to in the community, and we exchanged information, and she told me about her role, and I told her what I was interested in with research. Years went by, and then 4 years ago, I got a cold call from her out of the blue, and she said, I have $350,000, and I'm looking for a researcher to research something with dementia, but it can really be anything. Are you interested? And as a social worker, that kind of money does not come around very often. So without even thinking, I said, yes, I am so interested in that. And so that was really exciting. And that first year turned into a 4-year, multi-year project, which we're still in the middle of. And it's been up to $1.45 million. And so I'm going to tell you what we decided to do with that. And the question that we kept coming back to, I brought in my co-principal investigator, Dr. Jung Kwok from the School of Nursing, and we kept thinking, okay, at this time we're in year 1, we said we have $350,000, you know, what, if we can do anything related to dementia care, what should we do? And we kept coming back to this. How do we train the next generation of healthcare providers in dementia and interprofessional care? We know that there's a huge shortage in geriatric healthcare providers already, and healthcare providers that understand how to work on a team is so important. We train in silos, you go to medical school, you go to nursing school or social work school, and you're training with other people in your profession, and then you get thrown onto a team, and you might be the only nurse or the only social worker on the team. So learning those skills of how do we communicate, understand each other's roles, talk about conflict, all those things are really important. And despite the growing prevalence of Alzheimer's disease and related dementia, most healthcare professionals get little to no training in dementia and geriatrics in graduate school. And so hence the 40% of primary care physicians don't feel confident in diagnosing Alzheimer's disease. And so our goal was to create and evaluate an online curriculum for health professional students to learn more about dementia and interprofessional care. So we were hoping we could improve students' attitudes towards aging. We live in a very ageist society, wanting to move the mark on that, wanted to make sure that students understood more about brain health and dementia, and also wanted to make sure they built those interprofessional skills. And so we had to do a lot of coalition building. We started with the Center for Health Interprofessional Education on campus, and they have 2 of their key people in their department on our task force. And then we brought in content creators. These are faculty members from across these 5 UT schools, from the Moody College of Communication, Dell Med, the College of Pharmacy, that's supposed to say UT Social Work, and School of Nursing. And so those 5 individuals worked together with our task force for a year, and we developed a really amazing curriculum for health professional students that they can take online and earn a micro badge. And so they can put that on their LinkedIn and on their resume to say, I've completed this coursework. As I said, I have a connection with the Alzheimer's Association. I've been a longtime volunteer with them. And their vice president of public health programs is on our task force from the national chapter in Chicago, and they have helped us develop this curriculum. And then we partnered with LATES, and they're the Liberal Arts Instructional Technology Services, and they basically took what we had and gave it a facelift. They polished it, made it look beautiful, turned our content into animation, so it would be really interesting and active engagement for our students that were taking the curriculum. So we really wanted it to be case-based, and so one of the, this is a family from Module 2 from Brain Health, and then we have another family in the early detection treatment, or early detection module. So these are what students will learn about: interprofessional foundations, brain health, early detection of dementia and Alzheimer's disease, and then we just completed the new biomarker study, because as we know, the science is moving so fast, and it's really important that students really get the cutting edge of information about how to treat, how to diagnose, and care planning with all of those things. So I'll just read, because I'm sure it's difficult to read all these things. I'm going to read one of these things. As a medical student with interest in neurology, it is wonderful to have interprofessional curriculums where I can learn more about providing comprehensive dementia care. It was helpful to see the roles that the other professions play, like social work and speech-language pathology, when helping patients navigate a complex diagnosis like Alzheimer's disease. So we're now in year 3 of this grant, and we've had over 100 students go through the curriculum and earn micro badges, and we've done a pilot study, which we're working on publishing, and working with our state partners and thinking about how we can take that next step. So one of the comments that one of the students made during the pilot study is, this is great to learn about it, but I want to see, what does this look like in real practice? It would be great if you could have videos showing what does facilitating a family meeting actually look like. So we thought, okay, we can do that. So 2 weeks ago on a Saturday, we had a 12-hour filming day. And we had some of our clinicians from the Comprehensive Memory Center come and role play a family meeting. And we had a patient and a family member and our team do a role play of a video of what ideally best practice should a family conference look like. And so we'll be able to add that to the curriculum as soon as LATES is done editing that. So we're really excited about this work. We know that the older adult population is expected to grow by 82% by 2050, and there's a huge shortage in geriatric trained professionals, especially Alzheimer's disease and dementia. And so we're hoping that this first of its kind curriculum is available online. This summer we'll be moving to public facing, so beyond just UT, students enrolled in healthcare programs will be available to healthcare students in any program across the US. And so we're really trying to make that available to more students to really get that training. Okay, so I'm doing pretty good on time. All right, so did everyone complete the survey, or at least look through the questions? So we're going to talk through these and find out how much you know. I suspect that you're all very well-educated group of people. You probably know a lot of these already. Are Alzheimer's and dementia the same thing? No, that's false. Alzheimer's is one type of dementia. So in case anyone wants my brief overview of this, what I tell families in the clinic is dementia is an umbrella term, and there are many different diseases that cause dementia. The most common is Alzheimer's disease. 70% of dementia is caused by Alzheimer's disease. And so it's kind of like if someone were to say, I've been diagnosed with cancer, you might ask them, what type of cancer do you have? Where in your body is it? So if someone says, I have dementia, you can ask them, what type of dementia? Where in your brain is it? And now that we have new ways of diagnosing and precision medicine, we can actually see in an MRI and a PET scan. We're using amyloid imaging to diagnose our patients, which 5 years ago in clinic, we were not using PET imaging with every patient. It was a very rare circumstance. Now with every patient, we're looking at biomarkers, serum, we're looking at their PET scans, amyloid levels, to rule in and rule out the presence of amyloid and other biomarkers. So the field is changing rapidly. Dementia is a normal part of aging. That is false. Only old people can get dementia. That is also false. That's one specialty area of mine. I work with a lot of people who have young onset dementia, and people who are in their 40s and 50s who are diagnosed with dementia have a whole host of other challenges and barriers to receiving treatment and care, and just because of their life stage, things that they face. And so, let's see, where are we? There is no reason to get diagnosed. That's false. There's now more than ever with the new treatments available, there are really good reasons. I used to hear this all the time when I worked at the Alzheimer's Association, and I go to medical conferences and I'd be trying to talk with healthcare providers and say it's so important to diagnose. You would not believe how many healthcare providers would come up to me and say, why bother? I don't tell people that they have dementia. There's no reason to do that. And thankfully, now, fast forward all these years later, we have no excuse because we have some really great treatments available that can remove amyloid from the brain. And so I do see that shifting, the cultural shift in the healthcare system. That's still a little bit pervasive, but not as bad as it was before. More healthcare providers are diagnosing and referring to specialty care. We know this is false. There are treatments available. A caregiver is not always someone who is paid. Most caregivers are unpaid family members. It is true that caregivers experience high rates of depression, anxiety, mortality. 60% of caregivers will actually pass before the person that they're caring for. And a lot of that is due to neglecting their own health. I experienced that as a mother. I have 3 girls that are 10, 8, and 5. And I have to make sure I get my dentist appointments in and, all of those things. And it is really easy when you're putting someone else first, which is what caregivers do. They're making sure that the person they're caring for is getting all their medical care. And so they neglect their own. And so that's one thing I work with caregivers on in my counseling practice, is making sure that they are taking care of themselves. You do not need a diagnosis to participate in Alzheimer's research. We are looking for normal controls all of the time. Many research studies have 2 groups, a control group and a treatment group. And so healthy controls can really help us advance the field of research. You will not necessarily get dementia if your parents have it. Potentially at increased risk, yes, but just because you inherit one of the ApoE4 genes from one of your parents or both your parents is not a deterministic gene. And so it doesn't mean that you will for sure go on to develop dementia. And we'll talk about some of the things that we can do to reduce our risk. And you do not need an attorney to do advanced healthcare planning. I tell people that I work with, if you can afford an elder law attorney, it's a really good idea to meet with one. They can do a lot of things, documents they can draft up for you and trust if you're going to be doing advanced kinds of things. But for a simple medical power of attorney and a durable power of attorney and a living will, you can do those documents with a notary at the bank or, and just witnesses for the medical powers of attorney. So I think that's really important for people to know. Okay, shifting gears to the last part of our conversation here, the last 5 to 7 minutes, and then we'll shift to questions. Why does all of this matter? 7.4, so the Alzheimer's Association, every April they release the new facts and figures report, which is about a 150-page report. And since I imagine all of you do not want to read a 150-page report, I did that for you. You're welcome. So I'm distilling all of that information down into just a couple brief slides. I wanted to bring just the latest research to you, and so this was just published a couple of weeks ago. So now we know that there are 7.4 million Americans, 65 and older, living with Alzheimer's disease. That's more than the entire state of Washington. By the year 2050, that will almost double to 13 million. And unless we change the trajectory with treatments and modifiable risk factors. But I think when you think about the scale of the problem that we're facing with the workforce shortages and the aging population and this number doubling, that's going to be a problem and a strain on our healthcare system. We now know that the physiological changes begin up to 20 years before symptoms appear. So you think about, most people are diagnosed between 70 and 80, so we're talking in 50 to 60. That's when those symptoms start if you're looking at a clinical pathology, a biological perspective, not clinical symptoms. And so when we think about intervening, there is so much we can do at midlife that can impact our overall risk for dementia. And it's actually never too late. There's a lot of things you can do later in life to reduce your risk for dementia as well. So we're going to talk about some of those things. So a lot of the research that just came out on this topic came from the U.S. Pointer study. If any of you have been following the Alzheimer's research, this was a major breakthrough. They just published these results in July, and it was announced at the Alzheimer's Association International Conference in Toronto, which I had the pleasure of attending while they made this breakthrough announcement. It was just incredible because people were waiting to see what happened with this trial. So they had enrolled 2,100 participants. It was ethnically diverse. They assigned people to a structured program or a self-guided approach, and they targeted the 4 lifestyle domains that we know that are directly related to heart health and brain health. And so they had a structured program for exercise, cognitive activity, cardiovascular health monitoring, and nutrition. And while both groups had major improvements, the structured group, where they had facilitated support, showed significantly greater equivalent of being 2 years younger than the other group from a healthcare perspective. And so the reason this study really matters is that it shows that transforming our lifestyle advice that physicians give us, that it's not just a good idea, it's actually proven that we can reduce our risk for dementia and Alzheimer's disease. This slide is a little hard to read, so I'll kind of walk us through it. I think one of the most interesting areas of evidence that have come out in the last 3 to 4 years has been in hearing loss. There's been a number of research studies that have showed that individuals with untreated hearing loss had a 71% higher risk of developing dementia over 15 years. So untreated hearing loss, 71% higher risk of developing dementia over 15 years. So if your spouse or partner has been telling you that you can't hear and you need to get hearing aids, let me be another person to tell you, get those hearing aids. It's really important. And if you have hearing aids and you're wearing them, kudos to you for doing that, because that is one of the main things that we know can actually help reduce our risk for dementia. So good for you, for all of you who are wearing hearing aids. We also know that intensive blood pressure reduction can reduce your all-cause dementia risk by 15%. So if you are on blood pressure medication, keep doing it. That's what your doctor is telling you. That can also help reduce your risk for dementia. Some of the other, this is kind of summarizing all of the research globally that just came out. Protect your head, so prevent traumatic brain injury. We know concussions, car accidents, not wearing your helmet while biking, those things can increase your risk for dementia. Smoking significantly increases your risk for dementia. We know that physical activity is one of the best things you can do. I've heard more than one neurologist and Alzheimer's physician say, if I could choose between giving you a prescription for donepezil, which is kind of the main FDA-approved treatment from the last 20 years or so, or give you a prescription for aerobic activity 3 to 5 days a week, I'd have you do the physical activity. Because that has had so much research in so many countries and has been shown to be so impactful to our brain health. And it doesn't have to be running a marathon. We know that just increasing our steps can be really important for improving our brain health. Challenge your mind. You're all here tonight, so you all get a big bonus point for coming here and learning something new and challenging your mind. So cognitive engagement, socialization, which, I mean, Westminster has unlimited opportunities to do those brain healthy activities. We talked about blood pressure, managing your diabetes is kind of a general cardiovascular risk, managing your cardiovascular risks. Sleep, this is another really interesting area of research. I know Dr. Bill Schwartz was here talking to you about sleep not too long ago, but this is, I mean, just fascinating. Every year there's new research that comes out about sleep and how it's related to dementia. And so this is an area that I'm really watching and learning about as far as how sleep impacts our brain health. We know that continuing education builds cognitive reserve. If you have greater than high school education, we know that your risk of dementia is reduced. The more years of education you have, the more protected your brain is. And they call that the cognitive reserve theory. And if that's interesting to you, put that in Google Scholar, and all the research studies will come up on cognitive reserve, and that is just a fascinating area of research to read about. Eating right, mind or Mediterranean diet, what's good for your heart's good for your brain. So, we know omega-3s and nuts and berries and leafy green vegetables, all the things that we know are good for us to eat, good for our heart and our brain. And then obesity is also a risk factor, so maintaining a healthy weight. All right, so I promised Judy that I wouldn't spend the whole time just talking and that we'd have time for questions, so I'll leave you guys with this. These are 7 action steps that you can do to start this week based off of the last slide and the things I just talked about the last 5 minutes. So first of all, because I'm a strengths-based researcher, I want you to look at this list and think about, what am I doing well? What 1 or 2 things am I doing on here that I think, I'm doing a pretty good job of this. I'm succeeding at this. I have a good sleep hygiene routine, or I get all my steps in, or I go to lectures a lot. I'm challenging my mind. So give yourself a pat on the back for the things that you're doing, the things that you're doing well. And then think about maybe one of the things that I mentioned tonight that you feel like, I could maybe improve in this. I could wear my hearing aids a little bit more. I could do a better job of making sure I'm taking my blood pressure medication every single day, or I could go to sleep at the same time every night. So give yourself credit for the things that you're doing, and maybe pick one thing to work on in the next month or 2. All right, so it's never too late to work on your brain health. There's things you can do today that will have an impact, and advocate for your brain health at every single medical visit that you have. So with that, I'm happy to take questions.
Tell us, how do you get a I'm sorry, what's the bottom button?
Better. My first question is, how do you get a referral to your center? And is there a waiting list? How difficult is it to even get in to the center for a patient?
Great question. So getting a referral, ask your primary care physician to send a referral. So we are now on Epic as of 2 weeks ago, and so hopefully getting referrals will be a lot more seamless because many of the other outpatient clinics in Austin are also in Epic. But primary care can send a referral. We do have criteria. One of the criteria is that you have to be experiencing symptoms of memory loss. So if someone wants like a cognitive baseline, or they're not having symptoms of memory and they just kind of want like a baseline assessment, we don't do that. There are people in the community that do that service, but because there are so few dementia clinics, we really try and save the time of our specialists in our clinic for people who are currently experiencing symptoms of memory loss. Now, with that being said, the way that our scheduling has worked is that we schedule out for 3 to 4 months, and then our system shuts down for 3 months. And so that's when our wait lists kind of come to happen. So if you happen to get a referral during that time where the wait list, where our scheduling is down, then we have a wait list, and then we call a bunch of people and schedule for the next 3 to 4 months. And so it really just depends on kind of what time of year and when in that kind of process we get the referral.
And I'm sorry, I didn't understand. What type of doctor has to be the referring doctor?
Primary care, any healthcare
primary
professional,
care.
but usually it comes from primary care, but really any professional, any healthcare professional could send the referral.
My second question is, are you familiar with the drug donanemab?
Mm-hmm.
And do you all use that in your clinic?
We do write prescriptions for donanemab, yes. Mm-hmm.
Thank you.
Yeah. Yeah, we have about, I want to say 82 patients on the new infusion drugs, which I did not cover tonight because I'm not a medical professional. I don't prescribe those medications myself, but I do counseling with caregivers and families that are on those medications. And so the 3 main infusion drugs, the new disease-modifying treatments, yes, we do prescribe them.
I just had surgery a couple months ago, just my ankle, and I want to tell you that after the anesthesia, I did not feel good. I could not think. They tell me it can come back within a year, but sometimes you lose it completely. I would like to know. That's have not been fun for me to go through.
I'm sorry, that's been your experience. Must be really frustrating.
It's got to be illegal. No, I'm serious.
Yeah. We do work up people in our clinic who have memory loss for a variety of reasons, and anesthesia has been one of them in the past. And I know that that's not just your experience. I've heard that from other patients as well in our clinic, that after undergoing surgery and having gone under anesthesia, that has been a side effect. And I've also had people tell me it took some time, but their memory did start to come back. So
I would have liked to have heard that.
yeah.
I'll just make a mention. I have a nephew who's a nurse anesthetist, and I asked him about what anesthesias are less likely to cause cognitive impairment, and he gave me a list. So if anybody wants that, contact me, and I'll share that list with you. And some of it has to do with not only the type of anesthesia, but how long the anesthesia is under effect. So talk with an anesthesiology before you have any surgery at all to say what will minimize the impact.
Yeah, and we've had, I know our neurologists have recommended certain types of anesthesia or said to avoid certain types as well. And so definitely worth asking a healthcare professional about that.
Thank you for your presentation. It looks like the Dell Medical Center is getting ready to do this huge expansion, and they've got to be hiring all kinds of people. What I read is there's a brain drain in Texas. A lot of people are leaving because of the politics, and especially women of childbearing age are not willing to come to Texas. Have you experienced any of that in your hiring?
Yes. Yes, we have. I've had friends and colleagues leave the state for that very reason, absolutely. And it has made recruiting a challenge, to be frank with you, yeah. The political culture here in Texas does make recruiting hard. But I think that Dell Medical School, because of its cutting edge innovation and the AI native hospital system and kind of the package that we're offering, I think is lucrative. People want to come here and be a part of something different and be part of something really innovative. And so hopefully that will start to turn around. I know neurology is in one of the first waves for the hiring, and so we have I think they said 200 neurology faculty we're going to be hiring over the next 2 years. And so people from all over the world, it's going to be very interesting to see the growth.
Elections are coming up in November.
That's right. Vote. Go out and vote.
Who else has a question?
Are there any reactions to having an injection of reclassed that you know of?
The reclass. Can you say?
Reclassed.
Say, what do you, I'm sorry, I don't understand that question.
I was on Prolia for a while, and then they said, you've been on it long enough, you need to change to reclass.
I see what you're saying. So as a social worker, I try not to answer any specific medical questions about drugs or side effects because that's just not really within my scope. So I apologize, but yeah, I would say ask your healthcare provider.
Ted Turner died today, and he had been diagnosed with Lewy body, which is also what Robin Williams had.
Correct.
Could you comment on that?
Yeah, absolutely. So when I said that dementia is an umbrella term and Alzheimer's is the most common type, Lewy body is probably the second or third most common type. And so Lewy body is interesting because it usually co-occurs with movement disorder as well. And so oftentimes when we're looking at the clinical syndrome, we see people having balance problems and shuffling gait. Another, one of the hallmarks of Lewy body dementia is visual hallucinations, which is different than the delusions that people with Alzheimer's disease have. Someone with Alzheimer's disease might see a reflection in the window and think that someone is standing outside. But someone with Lewy body dementia it's such acute visual hallucinations that they really believe that these animals are here or these children are here, and they can describe it with such specificity. So that's a hallmark symptom. They often have a history of REM sleep disorder, so many, many years of thrashing in their sleep. A lot of times, married couples who come in, they've been sleeping in separate bedrooms for decades because of the sleep disturbances already. Another interesting thing about Lewy body dementia that differentiates it from Alzheimer's disease is that there's cognitive fluctuations. So this is different than just good days and bad days that people with Alzheimer's disease might have. This is someone in the morning who can tie their shoes, and then in the afternoon can't even, locate what a shoe is. And so really rapid cognitive fluctuations, even within one day, or will last several days at a time. And so to diagnose Lewy body dementia, we do a really thorough clinical history and symptoms and interview family members, imaging. And also, it's kind of considered one of the Parkinsonism syndromes. So it has a lot of similar features in the alpha-synuclein protein in the brain. So, yeah.
Anyone else with questions?
Are you associated with anything here at Westminster as far as their mental health programs?
I am not. I just have a couple friends that live here. And unofficially connected. But I'm happy to learn more.
Okay, I have a question. Probably it's a little bit offline, but let me ask it anyway. Have you people also looked into the possibility of the connection of dementia healing with the religious faith?
Yeah, with religion and spirituality. I think that spirituality is certainly a protective factor, and religion is a protective factor. And I think there's a lot of research to back that up. I don't think it's specific to any religion in particular, but I think that we know that depression also puts people at risk, and people who are connected to a faith community in general have, less experience of depression. They have routine where they're connecting with their community once a week. They're actively engaged in learning. And so I think there's many research studies that have shown the positive benefits of religion that I would imagine also kind of correspond and correlate to reducing your risk for dementia. But as far as curative, are you asking?
Okay, more specifically, I'm just wondering, within your entire structure, is there one little group or whatever it is, sort of a focus on the holistic related kind of issue at all?
Yeah. I will say that when we did our focus groups, when we were building our clinic, that was one of the strong things that came up was religion and sort of a general sense of meaning and purpose in life. And people who are living with dementia, that was one thing that they really wanted with their healthcare providers, is they wanted to be asked more about their faith and their spirituality, and they wanted opportunities to participate in legacy projects. And so that's kind of how we grouped those comments together from the focus groups. But the idea was like a way of giving back, whether it was volunteerism or writing a book or a memoir or a way of passing on their life experiences that was sort of existential. And so we do incorporate that into my social work interview. I always ask the caregivers that I'm meeting with for counseling if they're connected to a faith community, do they have a spiritual practice and what does that look like? So I think from that kind of strengths-based whole person perspective, we can't just ignore that. That's a really important part of a lot of people's lives.
Okay, actually, a little bit more specific. I'm interested whether or not maybe within your big organizations, is there a little telephone number for those who are interested in pursuing maybe a prayer or something related to the entire process?
Yeah, I'm not sure.
You know what I'm talking about?
Yeah.
I'm just talking about since you have such a big setup, is there any telephone number or any kind of contact information? So for those of you, for those who feel the spiritual approach might have some relevance in the entire big project.
Yeah, I think, I guess from our social work program in particular, so there's 2 social workers in our clinic right now, myself and Jess. And Jess is, he practices in the Zen Center as well, and he does a lot of lectures and mindfulness, and so he brings a lot of that spiritual practice into his sessions and integrates that in. And so I think it just kind of depends on, it's more of an individual provider, you know, what their life experience is, their area of expertise, but as an organization as a whole, at the Mulva Clinic, that I don't know if we have like an organized, you know, way of providing that. Okay, maybe last question, or I see two more, and then we'll wrap up, and I'll stay for a few minutes if others
Would
want
you
to.
elaborate a little bit more on inheritance factors involved?
Mm-hmm. So there's deterministic genes, yeah, and then risk genes. And so there are 3 deterministic genes that we know of, and that means that if you inherit that gene, you have a 100% chance of developing dementia. And so, you know, that would be like a Huntington's gene, for example. And so you can get tested for that. And there's a lot of research studies who are studying that population who has a known deterministic gene, and some intervention trials with that population. So trying out new medications to see, can we slow, can we stop and prevent dementia from happening in this group of people who we know with 100% certainty they will go on to develop dementia. Now, those are, you know, very unlikely. I mean, they're more rare, I guess is what I'm trying to say. And then you have your risk genes, your genes that put you at risk for developing dementia. And the ApoE4 gene is the most commonly known at this time, and that may even be out of date at this moment. Genes that put you at risk for developing dementia. So those are the main ones that we are looking at.
This question has 2 aspects. One is need to move our body, we get exercise for our brains. But I'm wondering what sort of exercise. Like, for example, should it be gentle or vigorous? Or should it be continuous or vigorous, gentle, like that? The other aspect is sleep. Should be whether it's continuous, maybe you say 7 to 9 hours. Should it be one block or can it be interrupted?
Yeah, good question. So I think with the question about physical activity and what kind of physical activity, I think a lot of the research in the longitudinal cohort studies has been around aerobic activity. But there's also been a lot of research outside of that on Tai Chi and yoga and chair exercises and walking. And so I don't think there's any like prescription for what kind of physical activity, but we know that, you know, like I said, what's good for the heart is good for the brain. And there has been a lot of research on Tai Chi, yoga, and mindfulness, even mindfulness-based stress reduction as well. So that's the first part of your question. The other one was sleep. I think from what I hear from the neurologists that I work with when they're counseling their patients is having a good sleep hygiene routine. So that's trying to go to bed around the same time every night, trying to wake up around the same time every morning. Now, with your natural rhythm, if you've always been a night owl, trying to go to bed at 9 p.m. is probably not realistic. You're going to lay there for 3 hours. So your time would be better spent going on a walk or challenging your brain or something else during that time. And then getting roughly 7 to 8 hours of sleep at night. But kind of following your natural rhythm of sleep, having a good sleep routine, they call it sleep hygiene, avoiding technology in the bed, you know, not being on your phone, even having your phone. They, you know, talk about blue light, you know, emitting, and that can impact our sleep. So those kinds of things, just practicing good sleep hygiene in general are the recommendations. All right, well, it is 8:15, and I want to be respectful of people's time, but I'll hang out for a couple of minutes. Thank you again for having me, and for the organizers here, and for the Westminster community.
And everybody, thank you.